Nuevamente, buenos días. Welcome back to Favaloro Foundation Hospital. Today we have a special guest, so we will speak in Spanish. But anyway, if somebody wants to ask a question in Spanish, don't worry, let go, because Marco can understand, or we can help him to understand. So let's go with the presentation. I would like to thank Juan Gaspar and Metronics, as always, because with their help, we can do these live cases in the hospital. On my right is Dr. Fava, Dr. Franco, Daniel, Matias as nurses. And here is an anesthesiologist, a technician, the echocardiographer. Everybody is here. And Leo, who is the technician from Medtronic, is like your Peter, Marco. So let's go with the PowerPoint. So this is our 7th case of this series that we have started some months ago. Let's go with the next. We are going to present today this live case of TAVR or TAVI using the cusp overlap view as we are using normally. Next. So, sorry, I would like to thank Antonio Pocovi, Diego Grinfeld, and Alejandro Cherro from CASI, and especially our special invited guest today, Dr. Professor Marco Noch. He is beyond being a great friend. He is Chief of Interventional Cardiologist at MC Medicor in Isola, Slovenia. And he also worked at the University Medical Center in Ljubljana, also in Slovenia. So Marco, you can say hello for everybody today.
So thanks for your kind invitation, Oscar. It's really a pleasure to join this case. So thanks again.
Perfect. I know Marco was busy talking about PFO. He's a specialist about that for many reasons that we will discuss later on. And you can read the Euro intervention online today, his own story. So this patient is a colleague. He has 67 years old. He presented with dyspnea in a few weeks ago. And his risk factor are hypertension, dyslipidemia. He's a current smoker. He's also obese and also stressed because his profession, he's still working. He has a previous history of prostatic cancer, which was treated with a hormone therapy, and a previous right coronary artery PCI in 2099. So the clinical diagnosis when he presented to his referral physician was coronary artery disease and a severe aortic stenosis. The next slide shows you the EKG, which is quite normal with the normal sinus rhythm, with a PQ of 180 milliseconds with the normal QRS and no other significant findings. At the Doppler evaluation and echocardiography, the transthoracic echo showed the normal left ventricular ejection fraction with 67%, severe left ventricular hypertrophy with a tricuspid severely calcified aortic stenosis with a gradient of 80 as a peak and 60 as a medium with a calculated area of 0.7 square centimeters. In the blood test, the only significant finding is this discrete elevation of, discrete renal dysfunction with a high urea, 70 with a creatinine level of 1.5. And as all the patients in the hospital are being tested for COVID 48 hours before the procedure, he hasn't have a frailty. And in the next slide is the angiography. You can see there the normal right coronary artery without restenosis, the left circumflex with the small branch occluded, and then the LAD. Next. So here in the AP cranial view, we can observe an ulceration and a lesion in the proximal segment, 2 lesions, one before the diagonal and the second one distal to the diagonal. Next. So there you can see in this photo a little bit better with an orthography that maybe you cannot appreciate very well, but he has significant calcification in the ascending aorta, which was probably the main indication for TAVR in this relatively young and low risk patient. Next. Next slide. So the heart team discussion that, previously was around the table, now is with the Zoom meeting, decided a stage procedure, PCI and TAVI. So next, we can discuss after my presentation while I am working about this lesion, how would you treat it, if you were treating the lesion or not after the recent publication. Then, sorry, no share the presentation, keep on with the PowerPoint.
Yeah. Oscar, ¿está bien así o una antes?
No, pero es que no estamos viendo el PowerPoint ahora. Dejaste de compartir.
No, estoy sharing my screen, ¿no? ¿La ven ustedes?
Ahí, sí.
Okay,
ahí. Next. So we pre-dilated distally, then we went to the diagonal that we decided to treat because we were treating the LAD. We deployed there a 2.5 millimeter stent. Next. There. A long stent with a 3.5 by 28 millimeters covering the LAD, covering the bifurcation. The diagonal was protected. We paid attention not to engage the left main during the implantation of this proximal stent. We tried to go from the LAD ostium until the middle segment of the LAD, and you can see there a good outcome. We decided not to proceed with any kind of kissing or additional procedure. Next. Next one.
Sí. Ahí está. Perdón, no pasa hoja. ¿Una más?
Yes, this is the final outcome. It's okay. Next. So this is the orthography. You can see that the descending aorta is quite normal, except in the abdominal part with significant calcification, also involving the common iliac arteries. Next. So this is the vascular access for the iliac arteries. As you can see, are huge arteries without significant tortuosity and some calcification in the right common femoral artery, but this in the posterior wall. So it's not affecting the percutaneous access that we are doing here. Next. So here is probably most interesting part, and probably some issue to be discussed later on. So this is a severely calcified tricuspid valve with these measurements done in CT. As you can see there is a 25 by 30 millimeters the diameter. The perimeter was close to 90. So there you have the measurements. But we did in the morning another measurements. Next. So as you can see here, the diameter is 23 by 29. So with the perimeter, with the mean diameter for 26 and the perimeter of 80. So a little bit smaller of the measurements which were done on the CT evaluation at the beginning. So it's exactly in the borderline to decide between the 29 and the 34 valve. Remember that the cutting point or the threshold is 81. Is that correct? Yeah. Next. So this is the coronary artery takeoff, which is good, acceptable, nothing to pay attention there. The significant calcification protruding a little bit to the LVOT, which is a little bit smaller with significant hypertrophy. This is the measurement of the membranous septum, which seems to be long, probably 7. You know that some teams are using these measurements to decide the depth of the implantation, trying to decrease the pacemaker implantation rate during the procedure. Next. This is the calcification in the ascending aorta, justifying the TAVI access. The patient decided not to take the risk of the surgery with this procedure. Remember that he is a physician. Next. This is the implanters view for the cusp overlap view, where we have been working for many years. Also with the help of Marco, we have the start experience there in Eslovenia. And we published this year. I think Carlitos was presented in the morning for your meeting in the CASI. So the implantation view should be right anterior oblique like AP with 0 with a caudal inclination of 12. Next. The coplanar view is left anterior oblique 21 and a cranial inclination of 10. So let me show what we have done so far for this procedure, and then I would like to hear your opinions and difference about the approach. Let's go. Vamos con la primera imagen.
Tenemos que poner solo en sala. Está sin compartir imagen de sala.
Compartamos imagen de sala ahora. Gracias, Juan. Compartir. There. Ahora vamos a ver con el floro y con todo, no solo mi imagen. One minute, please. Podemos cambiar la configuración para salir yo de la pantalla y ver la floro. Ayúdale, Hernán. One minute. There. So let's go back and we will show the angios that we have already done. Vamos con la primera imagen. So this is the crossover. Marco usually is using the Lima catheter. We are using the pigtail, but in this case, which is angulated with calcification, we are using the soft Terumo wire with extra support. I learned from Marco to use this wire. I would recommend to all of you. Next. And there, you know that we are puncturing under fluoroscopy test. This is the common femoral artery. We have the pigtail there. Next. We try to avoid to damage these small branches and to puncture in the anterior wall. Next. The only problem is some irradiation. We have deployed the 2 ProStars that we have here. This is a very obese patient, so it's important to have a divulsion there of the tissue before the artery. We have here a 7 French catheter for the control and contralateral 018 wire that you can see there in the fluoro for protection of the vascular access. And here we have a needle for a pacemaker. We will try to pace in on the with the wire and not deploy the right lead catheter. So being here, I would like to hear Marco, Diego, Antonio. Everybody wants to comment?
Oscar.
Yes.
Which is the oversizing for 34 or 29 that you have there? Just to keep clear, which size would you choose?
We have chosen the 34. You know that with the cusp overlap and significant calcification, we are not oversizing as much as we do we have done in the past. But in this case, which is you know, with the big annulus, with not a too small LVOT, so I would rather go with the 34. Probably I know that this could be arguable if you want.
Marco, I just wanted to,
I agree with you.
I would, you know, we're choosing the size. I would like to see more in detail the whole anatomy. What is the height of the sinuses? I saw LVOT is a little bit less than the annulus, but I think 34 would be a good choice. I haven't seen sinuses.
The sinus is, let me take, could you read this number there? Lee este número, no, vení, date vuelta. It's 30, Marco. No, 30. Here, ahí. El del medio, la flechita que señala la raya del medio, ese número. ¿Cuánto 37, dice? 37, Marco. 37 is the sinus.
Okay, so it's 34. for sure 34. And in this particular case, I would because of amount of calcium, I would probably predilate. We usually have predilation rate in about 30%, and this is the case I would use predilate.
We will predilate. We have prepared here the 20 balloon. We have chosen the 34, as I told you. The sinus measurement is 37, as I told you. And the sinotubular junction is 29. So I think we should go for the 34 for all these reasons.
Yeah.
For that reason, we have deployed or have introduced here a 16 French, because the 34 valve is 16. So we will try to prevent any kind of bleeding. When we have here in the 7 French, the pigtail and the wire in the same valve, sometimes you have some small bleeding that we have to not to pay attention to that. So feel free to any comment. I will introduce the wire and the balloon.
Oscar, why did you choose 20 millimeters balloon and not bigger?
This is a good question. I'm not predilating with bigger than 20 to prevent any kind of complication. Have you grabaste cuando cruzamos la válvula? Let me show another answer for the fellows who are watching the case. Next. This is something that we usually try to do. This is the real life procedure. It will take the same time we took to cross with the pigtail and the shade wire. Remember, this is not a hole. This is an hendidura, so you can cross it very easily with a wire like this. Marco knows.
Yes, you showed me several times, but I'm not so good as you, so I still use conventional, AL1 and wire. But,
yeah, I know, because you are using the LAO, because we have bad influences of an Argentinian guy, which is Flavio Rivicini. Marco is a very close friend of Flavio also, because Flavio is very close to Marco's hospital. It's 2 hours by car from Verona to Isola, where Marco is working.
Yes, and these are actually my teachers. Oscar was my first teacher and Flavio is my second teacher. And so I own my knowledge of TAVI to Argentina.
That's great, Marco. We can learn many things from you. So let me go. The valve is ready. Do you want? No, it's okay. Vamos a poner
Oscar, I just want to maybe to comment on the balloon size, because I do exactly the same. I go with very small balloon usually if I predilate, because I just wanted to open it. I don't want it to damage. So I never go, let's say, a short axis size balloon.
No. Thank you, Marco. So, yeah. This is the reason why I always go with no more than 20. Acabo dejando la guía lo más distal posible. I have forgotten to show you that we downgrade the shape of the wire to a very small annulus shape on the tip, and also introduce the second curve, as I showed you in the previous case, to help us for nose cone retrieval. We have decided to use the Confida, in this case, poner de frente, because this is small ventricle, very small ventricle, and so I didn't feel so comfortable. It's okay. To use the Landerquist. So my question for all of you, Vení Franco, is how many of you are using the Landerquist, as Dr. Gemal told to everybody here in Argentina?
I only use the double curve Landerquist when we have a very tortuous case. All the other cases, I try to use the Confida or the Boston wire, is the same. But we try to keep the Landerquist only for tortuosity and very calcified cases.
Yeah, it's almost the same for us. Vamos a la proyección de trabajo. Marco, are you using the Landerquist in some cases?
I have same strategy as described by Diego.
Perfect. Here, Carlos is remembering me something important. Let's go a little bit down. The orientation of the valve here, the port is at 3 o'clock. Yeah, so with this position, we are trying to get a perfect commissural alignment. No, because I am deciding the position of working is enfrente 12 caudal. No, caudal. Zero. So we are not crossing the valve, the annulus. Let me go here with the pacemaker. We will use 120 y vamos a bajar despacito, no cortamos. So vamos, we are going. Mark, ¿vos vas a hacer test? No todavía, dale. No todavía.
Perfect.
Do you like there?
Yeah, I think it's very good, and it's very interesting in this cast power left. There's no parallaxes. You never have parallax.
Absolutely. Subir un poco a 140. Dale. 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 Bajado despacito. Guardamos eso. So we are downloading the heart rate slowly to prevent the jumping. ¿Podemos ir una vuelta más? One more. No more. Okay. So we will do a test there. Seen it?
Good.
I think it's okay.
Good. Very good.
Vamos a la otra. Diego. Vamos a la otra posición.
We're going to check the from the left side.
Test.
It's okay.
Yes.
Leo? I think it's a good position. Probably I would to be a little bit higher.
Pero, todo permiso, Oscar. Te veo bien en el izquierdo y en el no coronario, te haces un poquito más abajo de lo que vos quisieras, pero estás a 2 en el izquierdo, ¿no? A 3. Y como a 4 en el no coronariano.
Claro. Vamos a inyectar de vuelta ahí.
Sí. Y estás como a 4 o 5 en el no coronariano y a 2 en el izquierdo.
Sí, yo creo que es una buena posición. Sí. Vamos a hacer un pull. Opinions?
I think it's very good. I would take the pigtail out and slowly release the valve.
We have a problem with the connection here at CASI, but now we are watching without problem. The position of the valve in this moment is perfect for us.
Okay. Let me go. Tenémelo ahí vos. O no sueltes nada.
Cacho, hay que ver cómo pivotea cuando la liberes. Tal vez se meta un poquito más.
Por eso he tratado de corregir un poco la posición.
Sí. Tal vez no sacarle toda la tensión, porque si le sacas mucho toda la tensión, tal vez va a pivotear mucho hacia el no coronariano y se va a profundizar, ¿no?
Eso es lo que le tengo miedo. We are discussing about the movement after release, Marco.
Yeah. No, I think if you retrieve the wire a little bit and release under pacing very slowly, it will be okay. It will stay there because it's a lot of calcium there.
Let me go. I'm not It's not possible to go again to the, probably occluded by the leaflet, the right, the non-coronary sinus.
Yeah, it's closed. A lot of calcium there.
Well, okay. Let's go for a test there. No. 15. Sí. I think it's okay.
Yes, very good.
Let's go very slowly. 120.
Do you consider pacing at this point as well? Yeah.
We are on this. Yeah. Más despacito, más despacito. Test. Very slowly. The valve is almost free, no tension there. We have pulled the wire.
Yeah, the liver is in the middle of the aorta.
Yeah.
Yes.
One more.
A small push to prevent any kind of traction. Okay, guardalo. So let's pull first the pigtail with the wire. Once again, I think it's probably 1-2 millimeters below. I like it, but I think I was not possible to deploy higher.
No, I think it's very good, Oscar. This is a 34 valve as well.
So there is when we use the shape of the wire to centralize the nose cone like this. And to prevent any kind of entrapment. Vamos de frente. Prepárate el introductor.
Do you have any changes in the EC key, Oscar?
No, the PQ seems quite similar. Probably some intraventricular conduction disturbances. You can see there, but the PQ is normal.
Okay.
Oscar, do you use echocardiographic control or in the
Yeah, we
lab?
have it.
Ah, okay.
Yeah. Podemos que se vea en la pantalla el eco. Vamos a hacer eco, así miramos. It's not as good as Marco echocardiographer because she's a lady and here is Dr. Ganun. But anyway.
I think echocardiography is very useful to have it all the time around.
Absolutely useful. You will see the echo. Déjale, moverle un poquito el paciente para allá, así Guillermo puede trabajar mejor. Ahí nomás, ahí nomás. No tanto, no lo pongamos tan cómodo que se va a querer venir a trabajar acá. No. Verá, vamos a ver qué se ve y qué ve. ¿Están viendo ahí el eco? Sí. Can you see the echo, Marco?
Yeah. Yes. I can see good contraction of the left ventricle, no pericardial effusion. The wire is obviously still in, but I mean, this is the most important part. Now we can go on and evaluate the valve. But I think it expanded very nicely.
¿Guille?
Bueno, sí, se ve que la prótesis está correctamente posicionada en cuanto a la altura. Está bien expandida. Vamos a buscar acá si se ve algo de leak.
So he's observing here a good position, well expanded. As you can see, they are circular in the short axis. Now Dr. Ganuno is trying to see some Favaloro leak.
Oscar, keep in mind that we have there 16 French shift. You gonna make a pullback or just for the big gradient?
No, I will introduce the pigtail to make the gradient. Right now, Guillermo is told me that we don't have any significant leak. So if you are not planning to post-dilate, we will measure the gradient. Mostrame un poquito más arriba, cuidado Guille, no te pegue.
Sí.
In your everyday practice, when you don't use a shift, say an introducer, do you test or evaluate the gradients?
No. I normally use the introducer set. Usually use the 14.
Okay.
Oscar, I don't understand why it's necessary to put the pigtail inside of the ventricle if you have the echocardiographic control.
No, it's just for teaching purposes.
Okay.
Right, yeah.
Okay, thank you.
We are supposed that we are presenting the cases not for you guys, but for the fellows in training. You are experts.
But in your daily practice, you don't carry out it, no?
Yes. Except in cases we have some controversy or something like this. In patients like this, I would like, dame esa jeringa con un poco de agua, to expand the patient. Because when you take out this severe stenosis in such a hypertrophic ventricle in a patient and then diuretic, etc., and so on, so the precarga, the preload is too low. Yes. And sometimes we have hypotension. So, Guille, te escucho. Dale, ¿qué opinión final?
Sí, que los gradientes están prácticamente normales como una válvula normal. La velocidad pico es 1.5, 10 de gradiente pico y 6 de medio. Nos quedó con un gradiente óptimo post procedimiento. Y no veo leak.
Okay. So we don't see any leak. The gradient, the peak gradient is 10 by echo. And as you can see here, it's almost 6, no more, 4, 5. With a good diastolic for this systolic pressure, I think it's good. So we will do an orthography before pulling the catheter. Let me.
Oscar, if I don't see, you have there block branch.
Un momento, porque me están hablando los técnicos. Callate un cachito, Gustavo. ¿Qué me decías, Diego?
Que según veo en el electro tenés un bloqueo de rama aparentemente. No sé si era previo o no. Es un bloqueo de rama que no es previo. ¿Vos al paciente lo dejás en observación 48 horas o lo mandás a las 24?
No. Todos los pacientes, sorry, Marco, no. For all patients, even without any kind of conduction disturbances, we keep the patient until tomorrow evening, at least, just in case. If we have some conduction disturbances, we stay in the hospital at least 2 days. In this patient with the normal PQ and with left branch bundle block, probably I wouldn't use the pacemaker, leave it like this, but in observation until tomorrow. Marco?
Yes, for sure. I think it's probably left bundle, but AV, but no AV block. So I would just observe it for sure on telemetry. And because the valve will further expand and this may cause some additional rhythm disturbance.
Cuidado un cachito, Guille, que te voy a pegar. Ponela, let's go a la posición de trabajo, 12 caudal. Let's go for our initial position for the final angiography. No, soltame un cachito. Sí, so you can see the ventricle. Okay, perfect. I think the position is perfect.
Yes,
you see
it's perfect.
coronary cuspid, probably 2 or 3.
Yeah, it's even less.
Minimal, so I couldn't post-dilate.
There's no need.
Oscar, you always use the wire like pacemaker?
No. Patients with previous
Ah.
conduction disturbances like AV block or probably also in a previous left bundle branch block, and for sure in patients with right bundle block, we use the pacemaker and we leave the pacemaker. Remember that Carlo knows better than me, but in the last probably 6.4 pacemaker implantation rate, but from these 5 patients, 2 or 3 were patients with previous right branch ventricular block. So in this patient, we have to be very careful.
Oscar, una pregunta. Pocovi, Antonio.
Sí, Antonio, qué gusto escucharte.
Gracias, igualmente. Fue muy lindo el caso. Te quería hacer una pregunta. ¿El marcapaseo lento, digamos, en la disminución de la frecuencia del marcapaseo, lo haces en todos los casos lentamente?
Sí, sí.
Okay.
Marco, the question is why we are using or slowing the pacemaker and not the sudden stop. Because with the sudden stop, sometimes you have extra systoles.
Okay.
And in some cases, the valve can jump out.
Okay.
He tenido un caso, Antonio, por eso ahora
sí.
No cuesta hacerlo así.
Es muy importante transmitir la experiencia, Oscar, eso sí, está bueno. ¿Y qué tamaño, no recuerdo, qué tamaño tenía en la medición de la tomografía el septum?
El septum,
7.9.
7.8. Sí, 7.8. O sea, era un septum largo.
Septum largo, está bien. Debería...
Vení de este lado. We are not going to revert the hyperinization in this patient because he has a recent stent. So probably if we don't have a complete sealing, we have to compress for as much time as we need. Are you reversing the hyperinization or no?
Yeah, basically, you know, I do the same as you. If the patient has a recent stent, I would not reverse. Or if I do peri-procedural stenting, of course, I don't reverse. But otherwise, in the regular case, I would reverse. And from time to time, I would use contralateral balloon for perfect hemostasis, as you taught me.
Yeah, you know, many physicians in Latin America are only using one proglide. I still use two, especially for a live case. But in a normal life, I try to use two. Because if you have a problem, you don't have any backup with one proglide. And this could be a problem, a real problem, I mean. Sultano? You see here, if you assume,
Yes.
we are not compressing at all. We are pulling the wire. We have almost a complete sealing. Anyway, we are going to compress because he's a very obese patient and I don't want to have a hematoma. Mostrame acá.
So, Dr. Marco, do you believe that maybe it's possible to do in the same time the angioplasty and the TDR?
Yes, we have probably 5-6 cases where we performed corneal angiography before. I mean, we got a referral of the patient and they say it is an intermediate stenosis, but we said, okay, let's make sure. So we performed angio immediately before TAVI, and was a tight lesion. So we, you know, of course we stent it and then we proceed with TAVI. Otherwise, I rather stage the procedure because to not to combine two procedures and two possible complications, and also in terms of contrast, these are old people and usually renal function is always an issue.
Yeah, you are absolutely right, Marco. The problem is I only have two cases our experience. The same PCI and TAVI in the same procedure. But in one case, it was a very easy lesion in the right coronary artery. And we ended up with rotablator, cutting balloon, and 45 minutes procedure. So I said, no, it's not the way of going. And let me tell you to the Argentinian physician, but Marco would understand the situation because in Slovenia sometimes is similar, not always the same. Here, you are not going to charge the health insurance for the PCI and the procedure. So if you have a complex PCI, you spend a lot of balloons, wires, introducers, and so on, you are going to lose a lot of money. And hospital authorities will call me, and I don't like to hear them.
We have the same situation, just I'm lucky they don't call me. Mirka doesn't call me.
First. So for that reason, I said, let's go with the PCI, be sure that everything is okay. And beyond that, I am remembering a case that it was a very complex case in an old patient that we did the circ, and we did a CTO in the LAD. And this patient has a pericardial effusion, and I think he had a very bad evolution. So for that reason, I prefer to separate the PCI and TAVI. Because beyond the money, in Argentina, we don't have high volume. So it's very important to keep good outcomes to show to your hospital, your colleagues, and the health insurance. And when you have a complication doing a procedure like this, I have already told you that you have a complication for the PCI, it's very difficult to explain that it was the PCI and not the TAVI procedure, where they are very reluctant to approve. So for that reason, I say, okay, let's go with the PCI and then do the TAVI.
Yes.
And you usually, Oscar, you know, I mean, because these are calcified arteries, even though it looks straightforward, you know, you might be struggling quite a lot because the balloon won't expand. And then, of course, you're entering a very expensive scenario. It's lithotripsy sometimes, etc. And I fully agree, if possible, you stage it.
And the other issue is most of these patients are very old, because here we are not allowed to do low-risk patients. So most of our patients are octogenarians. So patients like him, 76, is very unusual. So these patients have some, I mean, degree of renal dysfunction. So I think to separate the patient is also safer. So from our side, I think we are almost finished. Pone coronaria izquierda. Let's check the femoral artery if it is okay. And then we will be done. I also like to thank Alejandro Cherro and the CASI for receiving us there for a fellows in training meeting.
We have in this moment 80 fellows.
Perfect.
And I would like to know, Marco, how is the situation in your country, in Slovenia now, about the indication of the TAVI? Is possible to use in low risk? Is possible only use in high risk patients?
Very good. We can use in all patients, you know, because now rarely, you know, patients go to surgery. So I personally, you know, send to surgery, you know, I would say young patient or patient with very complex anatomy, including very calcified raphe in the bicuspid, etc., orthopathy, etc. Otherwise, you know, we have no restrictions that somebody would say, okay, you can use it only in high-risk patients, but low risk we send to surgery.
Marco, a common friend here. Could you explain that to him? Marco?
Oh, yes, I can hear you.
Could you explain to our common friend from the other specialty?
Okay. Yes. When I get a chance.
Dr. Favaloro, could you tell him about that?
Yes, when I get a chance. We always have a very nice chat on TAVI.
Alejandro, Antonio, Diego, ustedes, can you perform low-risk patients?
Nice to meet you, Marco. I know your country.
Oh, really? Okay.
Yes, I was there 5 years ago. It's beautiful.
Oh, great, great.
I was in Croatia and in Slovenia, but Slovenia is a very small country, but beautiful.
It's only 2 million population. Only 2 million. But, you know, we like the country a lot. You're right.
Yeah.
Very beautiful.
Yes.
The most important is very nice people.
Okay.
Mark is a very good example.
The lake with the castle in the middle of this.
Yeah, this is Bleed. I went there with Marco to eat a very nice cake.
Oh, you remember that? Wow, great.
Yes.
Oh, sure.
Like very much.
Mean, Oscar, which doesn't mean that we will not repeat that as soon as possible.
Yeah, I should. You know, Marco,
in my next trip, I would like to visit you.
yeah, of course. Antonio is welcome. Let me tell you, the hospital, Marco's hospital, where Marco is working in Isola, is in the top of the hill. So, meanwhile, patients, I go out to the balcony to see the Adriatic Sea. The view is amazing. Because we usually do 4 or 5 cases a day together.
Yes.
But I don't work.
I can see you, Marco, very relaxed.
Yes, it's always a good position, you know, when you watch others.
Okay.
But Oscar did an excellent job, such a great placement. I mean, this is textbook for CAS Power Lab, really.
And I just want to make a comment. It's you say in 45 minutes, we talk about coronary, we talk about many different things, but basically you end the case in less than 45 minutes, Oscar. So from my side, congratulations for that. Probably for the next time, we will need to have or 2 rooms or other case or the same case from the early beginning. So we can take advantage of your time.
Yeah, I was thinking about that, Juan, and you're absolutely right. So next time we'll start from the very beginning.
Yes,
because if we cannot finish the case, it's not important because, you know, we know how we will finish.
There is too many things in the early stage of the case that I believe, Alejandro, you can understand probably the CASI people, the colleagues that are doing the career there will enjoy from the early start. There is many different small details that need to take care. Remember that still vascular complications are the most important complication that this procedure has, and it will be interesting to see next time.
So we have used the angioceal to fix there. This is the other groin, which is perfect. We will put some bandage. Marco is not using the bandage. He leave it like this.
No, I use from time to time. If I'm not sure, I always use your bandage, Oscar bandage.
Okay. That's fine because you know, and the case is absolutely complete and done. So we will check the ACC. We have leave the sheath here in the vein just in case we need to put a pacemaker. But you see in the ACC that the PQ is absolutely normal with some extra systoles. So for my side, I will give you the final words to the CASI people and then to Marco, and then I will close you. Alejandro, Diego, something to say?
Thank you very much, everyone. Thank you very much, Medtronic. Nacho, un placer, gusto. Marco, pleasure.
Congratulations.
Congratulations for the presentation. Fantastic.
Thank you so much. Thank you for your help and for having us there. So, Marco, any final comment, thoughts?
I mean, I really congratulate Oscar. This is a perfect placement. You know, one shot, very straightforward strategy. Perfect closure of the femorals without even ProGlide signature. so no need to balloon. I'm just, you know, I didn't expect less, so to say, from you. Of course, you're my mentor.
Thank you so much, Marco. Well, thank you, everybody. Thank you, Juan. Next year, hopefully, we will have 2 rooms wired, so we can do more cases like this and probably combine it with other cases. Okay. Hopefully. This is a project still not complete. Anyway, I would like to thank you, Juan Metronic, for the case, for the help, for support, and we will see you guys in the next case, probably next month, if we still have classes and with the students, and then we'll take a break probably during January. Bye-bye.
Okay. Thank you. Gracias.
Thank you. Thank you. Congratulations.
Bye-bye.